Uh, like Dr. Bishop said, I'm going to be doing my presentation on POTS and the implications with SSRIs and SNRIs. So first, I have no financial relationships to disclose. So what is POTS? POTS is a syndrome of the autonomic nervous system. And what happens is the body is failing to properly regulate blood vessel constriction and blood volume upon standing up. So these patients tend to have symptoms that include heart palpitations, lightheadedness. They have diminished concentrations, shortness of breath, chest pain, syncope. Because some of these symptoms, they're unable to tolerate exercise, and it can just be overall very taxing on the body to move around. So this visual here kind of sums up the physiology of POTS and the orthostatic intolerance that these patients experience. One of the defining characteristics of POTS and diagnostic criteria is that difference in standing heart rate. So in adults, upon standing, their heart rate will increase about 30 BPMs, whereas for children and teens, upon standing, their heart rate will increase about 40 BPMs. Additionally, the heart rate and vascular tone, they fail to properly adjust when a patient stands, and this leads to that decrease in blood volume upon standing, as well as the increase in blood pooling in the lower portion of the body. So there are no clear causes of POTS. It's an idiopathic syndrome, but there are certain things that do trigger POTS. Some of those things being infection, either bacterial or viral, stressors like pregnancy or surgery, different traumatic events, or even immunization. It's important to note that though there are similarities between anxiety disorder and POTS syndrome, POTS is not directly caused by anxiety disorder. And then for diagnosing POTS, there are a couple ways that it can be diagnosed, but typically it'll be done with a tilt table test. So a patient will have no food or any medications prior to laying down. They lay down and they're attached to monitors, blood pressure monitors, pulse oximeters, and then ECG electrodes. And then that table will then tilt about 70 degrees. The doctor will monitor for any symptoms, and that will mainly be that increase in heart rate. So, again, 30 BPMs in adults and 40 BPMs in children and teens, and any symptoms or reactions to being tilted upward. Then the doctor will lie the patient back down, and then they'll recover. And usually that will end up in a POTS diagnosis if the criteria is met. So there are different classifications for POTS. They include neuropathic POTS, and that will be where there's some association with damage of the small fibers in the nerves. The hyperadrenergic will be associated with elevated levels of norepinephrine. Hypovolemic are associated with low levels of blood volume. And then secondary POTS will be as a result of conditions like diabetes, Lyme disease, or autoimmune diseases such as lupus. And then just important to note that the hyperadrenergic POTS is kind of the one that we'll be discussing the most or will be the most relevant to our conversation today. So in treating POTS, the main focus is symptom management. There are currently no FDA-approved medications to treat POTS, and obviously lifestyle modifications just with anything are going to be the first line. So that would include an increase in fluid and salt intake to raise blood volume. Additionally, medications like pyridostigmine or fludrocortisone can be used to raise blood volume. Sometimes medications like midodrine are used to raise blood pressure, and then beta blockers like metoprolol, propranolol can be used to slow down the heart rate, as well as ivabradine. So of the medications that are typically used to treat POTS syndromes, beta blockers and specifically metoprolol does have pharmacogenomic implications. So beta blockers in general are primarily metabolized by CYP2D6, and this enzyme plays an important role in the metabolism of metoprolol, carvedilol, nebivolol, and propranolol. However, currently, based on evidence, there is only CPIC recommendations for metoprolol, with the only actionable recommendation being for CYP2D6 poor metabolizers, which is to initiate therapy at the lowest recommended dose and then carefully titrate up to clinical effect in the guideline recommended doses based on indication. So that leads me to POTS and mental health. So like I said, even though anxiety does not cause POTS syndrome, there are quite a bit of patients with POTS that do have depression and anxiety. And this is because these patients are facing a chronic condition that affects their daily life. So just with getting up, they have that increase in symptoms. Again, they have exercise intolerance, and for some people, that could just be taking a walk. So the mental health aspect with depression and anxiety, these things are developed as secondary conditions due to the impact that POTS has had on patients' daily life. In children, sometimes this shows up as diminished performance on tests because they have difficulty concentration. And then in adults, they'll have that chest discomfort with the heart palpitations. Studies have also shown that about 87% of POTS patients show depressive symptoms, so a very high portion of these patients. And this study done by Anderson et al., it found that more patients with POTS meet the criteria for clinical mild to moderate depressive symptoms and report a sensitivity to anxiety compared to non-POTS patients. So this just further shows that impact that mental health has on POTS patients. So it showed that threatened suicide, there were about 37 patients compared to POTS patients, sorry, compared to the 19% in non-patients. And then for attempted suicide, it showed up in 16% in POTS patients compared to 3% in the non-POTS patients. So this study here was a randomized clinical trial, and it did look at different treatments for POTS patients. So it looked at 153 patients with POTS. They were randomized to four different groups, either being on propranolol alone, bisoprolol alone, propranolol plus pyridostigmine, or bisoprolol plus pyridostigmine. And of the 153 patients, 77 of them completed 3-month follow-up surveys. And what was found that in all different groups, the orthostatic tolerance had significantly lowered from baseline once initiating that treatment. And then additionally, there was a sub-analysis that was done that showed that even in patients who did not receive antidepressants, they had a decrease in their Beck Depression Inventory 2 scores once initiating therapy for POTS. The Beck Depression Inventory 2, it's just a self-reported questionnaire that measures the depressive symptoms and assesses feelings like hopelessness and guilt, physical issues, if there are any. It ranges from 0 to 63, with lower scores indicating less depression and higher scores indicating more depression. But overall, this just shows that just treatment of POTS itself can improve patients' mental health even without giving them any antidepressants. However, there are patients who have POTS and have diagnosed anxiety and depression, and these things are separate conditions. So there are considerations that we want to take into account when prescribing or recommending antidepressants for patients who have POTS. Currently, there is limited data on the use of antidepressants in POTS patients, but here are the number of antidepressants that are typically used, generally speaking, to treat conditions like anxiety and depression. So I want to specifically talk about SNRIs like desvenlafaxine, venlafaxine, and duloxetine. Because of their mechanism of action, they will increase norepinephrine levels in the patients who take them. And with POTS patients, specifically those who are hyperadrenergic, so they already have that increase in norepinephrine, this excess of norepinephrine can further increase some of the symptoms that they are experiencing, like the tachycardia, the palpitations, and blood pressure instability. So Overall, SNRIs are not recommended in patients with POTS because of that increase in the worsening of symptoms. However, with bupropion specifically, bupropion we know is a norepinephrine and dopamine inhibitor. So it does have some of that norepinephrine inhibiting like SNRIs, but to a lesser extent. And there was a study, a single center study that was done on 47 patients with POTS, analyzing for the reduction of orthostasis and improvement of symptoms with bupropion use. These patients were started on 150 milligrams of bupropion once daily and then titrated up to 300 milligrams daily. The study found that there was no statistical improvement in orthostatic vitals, but there was an overall reduction in reported syncope with a 60% positive response rate, sorry. So this just shows that bupropion could be an appropriate option for this patient population, especially those who are having a difficult time with syncope. Despite that increase in norepinephrine, it does show to not cause any further harm in this population. So it could be an option for those who have POTS. And then moving on to SSRIs. So SSRIs are typically what is recommended in this patient population. They have the ability to reduce venous blood pooling and increase orthostatic tolerance. They constrict the blood vessels to raise blood pressure and reduce dizziness and fainting. Like I said before, there is not a lot of information on the use of antidepressants and POTS. A lot of organizations that are POTS driven, so like POTS nonprofit organizations, will recommend paroxetine and sertraline specifically of the SSRIs. And I was able to find some evidence just to back that they are not harming these patients. So the first one was a randomized crossover trial with 39 patients with POTS that were randomized into two groups, sertraline 50 milligram group or the placebo group. So the primary endpoint was a standing heart rate of 4 hours. And what they found was that the standing heart rate and systolic blood pressure were not significantly different between the sertraline and the placebo group, but the seated systolic, diastolic, and mean blood pressure were significantly higher after sertraline administration. So this again shows that even though sertraline does affect the seated blood pressure, they did not have any impact on the standing heart rate, which again tends to be an issue for patients with POTS. Upon standing, they have that orthostatic intolerance. So it shows to be a pretty good option for these patients when looking for something that does not harm them. And this next case report looked at paroxetine treatment for a patient who did have POTS syndrome. So it was a 17-year-old girl who had recurrent syncopal episodes and multiple hospital admissions. She was first hospitalized and diagnosed with POTS in November 3rd of 2023 and was subsequently given increase of fluids, increase of salt, and was discharged. Then, about 6 days later, she was hospitalized again with syncope. And at that time, she had 10 episodes in one day. However, same scenario, she was discharged with lifestyle modifications. But 3 days later, she was hospitalized again with syncope, and then additionally, she had involuntary tremors. So at this point in time, they gave her paroxetine 20 milligrams a day. By day 3, from day 3 to 5, her syncope had improved, and then a week after therapy, she had no syncope that occurred. So she was continued on the paroxetine 20 milligrams a day outpatient. By December 28th, she had returned to the hospital with syncope, and so her paroxetine was then increased to 40 milligrams a day. A couple months later, in May of 2024, her prescriber reduced her paroxetine by 10 milligrams every 17 days, which led to a full discontinuation of the medication in July. And then by August, she reported on a depression scale that she had no symptoms of depression or anxiety, both of which she had developed throughout her multiple hospitalizations and current diagnosis with POTS. And then 1 month later, sorry, or really just a couple days later, by September 9th, her upright test, so that tilt test that's done to kind of diagnose POTS, had negative results. So it does show that paroxetine had an overall positive effect on her syncope and helped to treat some of her POT symptoms, sorry. Additionally, it did also help with her depression and anxiety, proving to be another option that can be used in POTS patients who are dealing with mental health that will not negatively affect them. So then just to wrap it up, there is not a lot of data on the use of antidepressants in patients with POTS. SNRIs are typically avoided because of that increase in norepinephrine that can already be an issue for patients with POTS. Bupropion has shown to have some improvement, especially with syncope in this patient population, so it's an option. And then SSRIs are going to be the ones that are more recommended in this patient population, with sertraline and paroxetine specifically having some evidence to show that they are not causing harm to this patient population.